Susan, I wanted to make sure she's the Vice President of Clinical Integration, and Stacey, you're the manager.
Yes.
And they're going to talk today about population health, care advisor. Are you going to touch value-based?
Yes.
Awesome.
Right.
So
I am Susan, and I'm going to go ahead and talk about what is population health, clinical integration, and some of the terminology you might hear. And then when we get into the real work and talk about nursing, Stacey will continue with the nursing part of care advising. So I'm going to kind of come back here. So population health is one of the terms you're going to hear a lot at Parkview. And that looks like it's talking about the health outcomes of a group. So there could be multiple different kinds of populations, but it's very easy over here because your population is the cardiac patient. It could be in a primary care office. They may have multiple different types of populations we're looking at, and it's mostly the chronic care patient. So when you hear population health, most of the time they're talking about taking care of the chronic care patient who consumes a lot of energy, resources in the hospital, and costs a little bit of money. The clinical integration, then, Parkview about 3 years ago started a clinical integrated network called Parkview Care Partners. And in that's the coordination of patient care within the physicians. So cardiology physicians are a part of that, as well as primary care physicians. There's neurology, there's ENT, there's different groups in that. And they're working on looking at metrics to coordinate care from, and I'll use CHF as an example, where it comes from the primary care. Did they do what they needed to do with a CHF patient? Did they do all the lab tests and tests they needed to do before they moved that patient onto a specialist? So one of the things they're working on at the coordination of care right now is, if the primary care is moving that patient to a specialist, have they done all the tests that your specialist needs, so when the patient comes, they don't waste a visit, that they get the right, they can make diagnosis because they have the testing done, versus the patient seeing your cardiologist, and then the cardiologist says, now you have to have all these tests so that I know how to treat you. So that would be a nice step for the patient and the cardiologist to have the tools they need to take care of that patient. So that's a good example of something they're going to work on this year. And then Accountable Care Organization is a organization that works on quality metrics for reimbursement. And you're going to, we are not an actual ACO, but we're doing the work of an ACO. So I'll kind of explain that as we go. The key of all this is the right care at the right time at the right place. Is the right doctor seeing the patient? Should it be, are you seeing patient, a good example is in diabetic care. We don't have very many endocrinologists at Parkview, and so the primary care need to take care of as many diabetics as they can, but if, like for instance, when the patient goes on to a insulin pump, is there enough access with the endocrinologist for them to take those patients, because they're not seeing all the new diabetics and stuff. So who's getting the right care at the right place at the right time? So here's our team at Parkview. So as you look at the population health team, you have the physicians. They're the key people in Parkview Care Partners. Right now, they're working on models of care. They're looking at, do we have enough access? Do we need clinics? Do we need discharge clinics? Do we need new member clinics? Do we need pulmonary clinics? What do we need to do so that the patient gets the care they need at the right time? And then how can they reach out to those patients to make sure that they're seen when they need to be seen? So you know you've got a lot of patients that come routinely into the office, but do you have enough office time for the patient who needs an urgent visit so that they don't go to the emergency room? So it's kind of, who do you shift off those routine patients to? Do you shift those off to an NP and have the physician do the others? So it's a lot of work the primary care has to do. Cardiology is great at it because you have your own ways to take care of emergent people, you have your clinics and stuff, but primary care needs to really learn from cardiology. Then you have that, we've got on-site care advisors that Stacey will talk to you about in a minute, who are actually embedded in the physician's offices, and we're looking at putting one in the CHF clinic here this summer. We have the care advising team who does referrals, has social support specialists there to work at social needs, does medication assistance, and we have coaching. So what percent of a normal chronic patient do you think is dealing with social needs versus medical needs?
Well, to me, social needs are huge.
It's huge. It's about 60% of the issues that we deal with are social. So, you know, you may be seeing them here in the clinic all the time and wondering why things are not happening. It's because when we go into their homes, you find things that are just, you would never think would be the reason that they're not taking their medication or the reason they don't weigh themselves or those kind of things. So the social needs are huge. Then you go into the clinical integrated network, and that's where we're having, which you hear the physicians talk about their dashboard and how they're being measured for incentive plans and how the payers are looking at it. And then we have a team that does just outcomes, that looks at how well we're doing in everything we do. So that's the team that's being built. It's been in existence about a year. So what are value-based contracts? And how do we pay for everything we just showed in the last slide? So each of our payers pay us to do work for them. So in one terminology, you'll hear per member per month, or PMPM, and that means they give us like $4 per member per month to take care of these patients. So it's a risk population. In insurance, it's a risk, so not everybody is high and chronic. So that's where we're making having the money to hire the nurses to go out and do that. So they are Parkview employees, but the funding is coming from our value-based contracts. And then we look at how do you measure how well we're doing. So in the physician component, in the clinical integrated network, they look at wellness measures. So a good example is the A1C. So they're looking at if we can control a diabetic and that they don't have an A1C greater than 9, then you catch them early before they become very chronic. So a lot of the wellness measures, a colonoscopy, a mammogram, so we're all women in here, for the mammogram, if they can catch a nodule or something early before it progresses, it's much easier than if we go and it's full-blown cancer or something like that. So it's a lot of that prevention. Then there's utilization measures where they're looking at readmissions, and do the people go to the ER because they can't get into the office? Are the offices telling them to go to the ER because it's 4 o'clock and they don't want to see them? What are the issues that are causing the patient to go to the ER and spend a lot of money and not get the same care they would get as an office visit? Because the ER is there to fix and just do an immediate fix, but not do care plans and not work at their whole level. And then we're measured on how much we decrease the monetary expenses. So that's good. So the chronic care is an example of that, where they have a lot of expense if we're not managing it correctly. So who are the payers we're talking about? This is the group that we have in 2016. So our commercial products are Signature Care and Anthem, and Medicare Advantage or Humana United, then Medicaid and self-pay. So those are the people that we focus on that we're getting paid. So we get enough money when we talk PMPM to help other patients as well. So as need basis, we will take care of other patients, and Stacey will get into that in a minute.
How many people do we have? How many members are we taking care of? Approximately
100,000.
100,000. I'm sorry,
Right
I
now.
missed that.
Right.
Thanks.
I don't think I said it. So, and then who do we see? So if you look at the very top of the pyramid, where it's kind of in a maroon color, that's the patient who has just been in an automobile accident and needs to go into traction and needs to go into rehab. That's not the patient that we're seeing, because there's nothing you need to do that. Or the patient needs a heart transplant. We're not going to say, no, I don't think so. So that's not the patient we're looking at. We're looking at the red. The red group is basically the high-risk patients who have chronic conditions. That's the group, that 5%, that cost a lot of the spend. The next area, which is the orange, is that what they call the rising risk. Their conditions are not under control, but they're not really complex yet. So those are also the patients that you have here that maybe a new CHF patient that's having some episodes, but they're not advancing themselves in the chronicity, but if they don't take care of themselves, they will get worse and worse and worse. So we have to look at that rising risk as well. And then the low risk are basically the people that are just come in 1 or 2 times. You check on them after they've come in with a bad episode, and then they're done. So Stacey's going to go through how do you know if we have a care advisor and what do they do?
So in Epic, probably the easiest way to see if there's a care advisor, there's 2 spots. One is here in your documentation. You're going to see the encounter type of care coordination with the Department of Pop Health, and you'll be able to read our note that we put in. When you click on that, the other spot is under the snapshot on the care team. You'll see a care advisor listed when you look at team members on the snapshot. So those are the 2 spots that is really pretty easy to find us. In the encounters, one thing that you'll see most of the time, the very first care coordination is our referral. And it might be worded and you think, what on earth does that mean, kind of strangely. It'll say a referral for population health, and it's given a priority score of 1 through 5. And so you understand what that means. If it says post-discharge visit, it's a score of a 4, which means it tells the care coordinators how quickly do they need to get in contact with that person. So we're looking at 48 to 72 hours that we need to get in touch with that person after they leave the hospital. A score of 5 is someone who we've determined is going to be possibly at high risk to return to the emergency room or the hospital, and we need to get in touch with them within 24 hours. 3s are patients who are chronic conditions, who maybe could wait a week or so. If we have a lot of 4s and 5s we need to get in touch with, those are patients that would go after that. And then 2s and 1s you won't see a lot of. 1s are really our coaching patients who just need someone to call and say, hey, have you taken your medicine? Did you follow up? And have you done this next piece of reading you were supposed to do, or whatever it is that the care advisors have worked with them on. So that's the different types of referrals that you'll see, and then the next note you should see would be our first attempt to contact that patient, and then it goes on from there. So referrals, Susan talked about the insurance plans that we cover and who we will work with. The next piece of that, after you get past the payer, is looking at patient conditions. So as she talked about, someone with multiple chronic conditions or a new diagnosis of diabetes who maybe needs instruction on their diet or insulin administration. COPD and asthma patients, we have a registry that risk stratifies the COPD patients to help us identify those that are at highest risk for coming into the hospital or who need the most coordination. CHF and cardiovascular disease patients. We also look at patients who have been in the ER 3 times in the last 3 months. So someone who, we get a list every morning that shows us people who keep coming into the ER with a diagnosis to help us pick those patients out. Maybe they're frail or something is happening that's not being controlled in their home situation that's causing them to come into the hospital. Non-adherence with their plan of care for multiple chronic conditions. A lot of times, unfortunately, you'll see patients with diabetes are not adherent to their plan of care because they can't afford their insulin. The insulin cost is just, it's really unbelievable how much some people have to pay for their insulin or their inhalers if they have COPD. So we have a medication assistance coordinator who can help with that in terms of getting some of those medications paid for. Pharmacy compliance or patients with 8 or more prescribed medications, behavioral health issues, people who require assistance with their ADLs. One thing that we've been working on is trying to, traditionally insurance does not pay for someone to come in and help with just basic ADLs. Cooking, cleaning, bathing, those kinds of things are not typically covered unless the patient has another skilled need. And so we've been working with some personal care agencies to try to see if we can get the insurance companies to provide that as part of their benefit to help keep patients out of the hospital. And then someone kind of falls in that category, frail, lives alone, and has little to no support.
Give me the example of the one you had the other day.
Oh, So one of the patients that showed up on the 3 ER visits, and it was actually in less than a week that they were in the ER 3 times. And so when I got to digging into the chart, what it actually was a wife. They'd been married for 60 years, a wife who had dementia that had gotten so severe that when she came into the ER, she didn't know where she was. She wasn't, recognizing things. It was pretty advanced. And her husband had been hospitalized, and he was her primary caregiver, and she needed nursing home placement. And so home health care was in there working with the husband, and instead of getting the patient placed, they kept sending her into the emergency room for emergency nursing home placement, which then wasn't taking place, and they would send her back home. And in the end, what happened was both husband and wife were placed together when he was discharged from the hospital. But in that short-term period, she had been left alone at home, unable to care for herself. And a neighbor brought her in, and different people would bring her in, trying to get her placed. But it was a not good situation. So those are the kinds of things we see that if we can get involved, we can try to work with and coordinate and try to prevent from happening.
I have a question. Is there any transportation assistance?
Yes. Yes, we're working. CityLink has a great program that people can qualify for. We have bus passes that we can use for people that live in town. And then in the communities, each community has they're all a little bit different, but they all have their own form of transportation that's available, so we do work on that.
And the example that Stacey gave you on that couple that was an example where the real issue got missed every time that patient came to ER. Home care missed it because they were dealing with the man's wound, and it wasn't until you started seeing that this patient has come back many, many times in a week that you've got to say, something's going on here. What are we doing? And grab that. And that's one of the things the hospital, we all need to work on as far as coordination, because the dots weren't connected yet. So.
This just tells you how to make a referral to us. You can either just send an email to careadvisor@parkview.com or care.advisor@parkview.com, or our phone numbers. But it talks about within Epic, you can place a referral in a patient encounter under meds and orders. You can either type in ambulatory referral to care management, or it's referral 221. You go into the database lookup. And the patient, when you're choosing an option, there's several choices: medication assistance, chronic disease education, different things like that. But if you don't see your reason, please pick other and put in what you believe that patient needs. And the more information you can give us, the box does have limited characters, but the more information you can give us, the easier it makes it for us to go out and see the patient and know what they need. We do go through and read the chart before we go to try to figure it out if we don't have enough information, but any little clue you can give us helps. And so then you're just going to finish the rest of the steps to complete the order.
Now, I want to make sure that you all are aware that this is an addition. You can have a patient that has telehealth,
Yes.
home health,
Yes.
but you know that Rhonda just had a situation, something was missing. So we put in a referral,
Right.
and they can go and assess all aspects of that care of that patient. Because home health care is there for a purpose. Telehealth really isn't there.
Right.
The computer, all that information is there, but not a person that can see socially what's going on.
Right. And we do in-home visits like home care does. We don't do hands-on care, but we do in-home assessments, and again, looking more at those social needs that those patients have to try to address those issues. And then this is a listing of all of our embedded care advisors. We have care advisors at PPG on Lake, New Haven, Carew, in Huntington, Whitley, actually she's in Noble, Nicole's in Noble, and Kosciuszko County is where Jill is. Tammy's in Angola. We'll have someone here at Cardiology. Our goal is by August, and then at New Vision. So that's where we're embedded currently. Those locations were chosen based on the populations within those practices. When you look at those physician panels and the payers and the chronic conditions and high risk of those patients, that's why those locations were chosen. We will take care of any patient that meets criteria for PPG, not just at those locations, but that's where we've embedded our care advisors. And embedding has had a tremendous impact on the use of the care advisor because we're right there. So when the patient comes in for a visit, they're there and we can meet with them in the office. Sometimes people don't want you to come to their home for a variety of reasons, but we still have the ability to sit down and meet with them, and then eventually we can usually get that home visit in once they feel more comfortable with you and start to build that relationship. So those are all the locations where we are currently embedded at.
Is that
So-
Carew one, the one that's the PPG offices?
Yes, at the internal medicine office on Carew. Second floor.
IMPs, right?
Yeah.
So if you have a patient that's coming in here, has been in the hospital, but lives in any of these areas, our outreach is out there as well.
So I didn't have someone go to Ohio.
Yes.
It was wonderful.
Yes.
That was very appreciative.
Any questions for us?
You look like you had a question.
So, like, we have the office at the corner of Carew and State.
Uh-huh.
And so if we put in a referral there, would Mary Ann then come down to, you know, if the patient lived, say, in Angola, and our nurse puts in the ambulatory referral, would Mary Ann then come down the street to us, or?
We can do it one of two ways. If it makes more sense for the patient to be seen in the office, or if it makes more sense to do the home visit, we can do whatever makes the most sense for that patient.
Okay.
So it might be Tammy that in Angola that
Yeah.
actually,
Right, that's what
Engages
I
with
was
them.
wondering,
Right.
because of our location of our
Right.
office.
Right.
If then, okay.
and they work within each other to coordinate that.
Yeah.
Do you have a printout of this, to like how to get in and all that?
Yes. I'll just send this to Denise and Doug.
What was that?
I'll just send it.
Oh, that
PowerPoint.
yeah, and I'll put it
Yeah.
in all the,
Right.
all the HUD books.
What questions do you have about what we do or what we can do?
You,
Well, I asked Denise if we could get a physician's order, and she said no, we
No.
can put it in
Well, I
ourselves.
just,
Right.
yes. And the other thing is have you guys gotten it routed to your in-basket or
Oh, yeah,
your
I'm glad
phone
you asked that.
nurses? You've gotten them, right?
I've seen it on the,
Because you're unable to add to their encounter.
Yes.
It's a closed encounter. You can read all the information, but we can't open and add to it. So we would have to, essentially, if they called,
Right.
you'd have to essentially do a telephone call because you can't add to that encounter. So I wanted to make sure, but you can read it, of course.
Yeah, and we have been talking about that, trying to figure out if there's an easier, better way to do that. But the other thing is that you'll see, after the care advisors go out and see the patient, if they have a need that's really not pressing that we, don't have to call someone about, we put those needs in bold in our note, and then we route those notes to the provider to try to bring that particular piece to your attention, like, I'm trying to think of an example of something that's not urgent. Could I refer to home health care, something that could wait a day or two depending on the situation. But if they have a need where there's confusion about medications or the patient's not sure what they're supposed to be taking, we will call, and that's when you'll get those phone calls.
It's like essentially, one I took was, the patient was supposed to be on Eliquis and they couldn't afford it and they just quit taking it
Yes.
and never called.
Yes. We run into that quite a bit, and that's really the pieces that we find very often are patients who can't afford their medication, and they don't want to tell somebody, or they're taking half their dose because they can't afford it, and they don't want to tell somebody because, either they're embarrassed or they don't think there's anything that can be done about it. And a lot of times when you call and you talk with the patient and if you know that the issue is medication compliance, when we call and say, I really just want to come out and see if I can help you, there's programs available, a lot of times that's the end to let you get in to see that patient and talk with them. When a referral is made to us, we do call, when we call the patient, we say, your doctor asked me to call you, so we do put that piece of it in there to also help build some confidence with the patient so they know that, okay, this person's for real and my doctor wants them to come and talk with me, so that helps too. Yes?
so is there a cost for your services?
No.
No, because it's paid by the insurance companies
That's what I wondered.
for the patient.
Okay,
Which is also why it's limited to those payers. because of it being, paid for by the insurance, that we have to be careful that we're not giving it just to everyone. Now, if there's a patient who's not one of those payers, who really needs assistance with something, we do try to connect them up with other resources that we're aware of that would be able to help them, that, are not necessarily us going out and making the visit, but connecting them with those other community agencies that can help.
If we place the referral, is there a specific time frame we can have the patient, I guess, anticipate a phone call?
Typically, the longest it should take is a week, depending on the urgency of it, but it should be sooner than a week before they hear something, but that would be the longest.
And if it is urgent, please tell us
Yes.
that on the referral.
Yes.
Because they're out doing visits and stuff, so they don't always get to everything during the morning because they're out scheduled, but we can take care of that.
Yeah.
Is there a point that you like sign off or discharge a patient, and if you do, and they have new issues, you need to put in a new referral, or how does that
Yes.
work?
If we discharge, what you'll, when you could maybe see previous notes from us, but then if you look on the care team and our name's no longer on the care team, that would be your indication that we're no longer seeing them and you would want to put in another referral. And you can see sometimes too, that we've been working with someone and then all of a sudden they quit answering the phone, or they don't want your assistance anymore, and you can kind of see that trail off if you read our notes too.
So if that patient then starts coming back into the ER or back in the hospital, we're back on them again.
Yes.
Because we'll get another referral automatically in those situations that, they might plateau for a couple months, but if they start up. And one of the things we're finding in the 3 visits in 30 days is we're starting to see behaviors before they get admitted. So we just started that at the beginning of this month, and that's very eye-opening for us of what's going on. You'll also see one more thing. Well, you also see notes from a paramedic because the community paramedic program reports in through this, and so when we need coaching, or we're just going to start sending them out now to those patients who have come 3 times in a month to see what's going on, you'll see them under the population health as well, but it'll say paramedic instead of nurse.
So are staff on the units aware of this service so that if they see a patient that would benefit from this before they?
Probably not.
Okay.
Probably not well.
The other thing is, and we do need to do that, the
Right.
other thing is we come into the hospital and try to see patients while they're here, before they're discharged, to introduce ourselves so they know that they'll be hearing from us. So that's another contact point that you'll see.
Is there a number that we can call if we have questions? Or
Yes.
would you prefer? Okay.
It's on that list. I
That's
just
good.
sent it to you. Right.
I'll put that in there. Thank you.
All right, thank you.
Thank
you.
you.
Thanks.